This is rapid sequence intubation, or more accurately, this is a talk about how we definitively control an airway through paralysis, and the focus needs to not be on rapid. Maybe we should be talking about really slow intubation, or delayed sequence intubation, which I'll talk about, because it's really more appropriate. The issue is that rapid isn't always good. When we go fast, we have problems. One of the things we do is we fail to pre-oxygenate adequately. We increase the chance that we're going to make medication errors because we're rushing. We increase the risk of vomit or aspiration because we rush past the important steps of positioning and things to protect the airway. And we actually decrease our skill performance or our ability to do what we need to do because we're in that amped up, adrenaline overloaded, sympathetic overstimulation that does not contribute well to either good performance or to good cognitive reasoning and good decision making. So what we're going to talk about is paralytic-assisted intubation, which is probably a better term for what we're actually accomplishing, or delayed sequence intubation, which is a more recent label for this to give it a more accurate description of what we're actually trying to do if we want to both secure the airway and make sure that we don't allow our patient to get dangerously hypoxic in the process. We administer drugs to sedate and paralyze a patient in order to secure an ET tube. And hypoxic conscious patients are the ones that are going to benefit the most. Those patients that are at risk of imminent respiratory arrest are the ones that are really going to benefit by us taking over with definitive control of their airway. But they're also the patients that are at high risk. So keep in mind that paralysis in the field is something we are allowed to do as paramedics in order to secure the patient's airway. It's not to keep the patient controlled. It's not to keep the patient from being combative. It is simply to help us accomplish definitive airway control. And it needs to be kept in that context as we think about how we're using it, why we use it, and how we can do it safely. So the basic procedure, there's a lot of steps involved, and it really needs to be systematic. We need to pre-oxygenate our patient, and that needs to be a priority from the start, which we'll talk about. We need to position our patient, and this often gets overlooked. A lot of times our most critical patients are found supine, flat on the bed, flat on the floor, on the ground, and that's the least ideal position for ventilation or intubation. We need to plan. We need to take enough time to make sure that we're doing this intelligently. We need to prepare our equipment, and that has to include a plan B and a plan C. We need to plan out who's going to do what, who's taking the airway, who's pushing the drugs, what are the roles and responsibilities so that we have a clear idea of who's going to perform each task. And we need to sedate our patient. We need to sedate our patient early, and let the sedation start to kick in and very quickly follow it with our paralysis. Some choices, the most popular currently are etomidate and ketamine for some very good reasons. We need to think about analgesia. And the only reason I have a question mark here is whether or not there's some discussion about whether it belongs here or after you've accomplished the intubation. And some pretty good arguments that getting analgesics, again, our sedative drugs just sedate. They don't do anything about pain. But pain management needs to be part of this, and there may be a good argument for doing it even before we do the intubation. Once we give our paralytic, we need to stop ventilating our patient. And this is really counterintuitive, but we need to stop ventilating our patient so that we don't force air into the stomach, increase the chance of aspiration, create more complications for ourselves while the paralytic is taking effect. But during that time, we still provide oxygenation, and that's when we talk about apneic oxygenation. We wait until they're totally relaxed. We want to make sure they're truly paralyzed before we go down and risk stimulating their gag reflex, and then we intubate them. As soon as we've intubated, we need to confirm placement through the usual means. We need end-tidal capnography as an absolute standard. And then post-intubation, and this is quickly post-intubation, we need to continue our sedation. We need to do pain management if we haven't already initiated it. And if we did already initiate it, we need to continue it and maintain it. And rarely, there may be a need to consider continued paralysis. This used to happen more frequently before the recognition was made of the need for analgesia. Sedation alone may not be cutting it. So even some of those patients who are really well sedated are still fidgeting, they're still agitated, they're still bucking the tube, and that's very likely because of pain, not because of inadequate sedation. So sometimes we were getting to a point where we're sedating to the extreme of what we're allowed to use in terms of dosages for sedation, and the patient still wasn't under control. And the next solution was, well, let's do more paralytics. Let's keep them paralyzed longer. if we adequately sedate and we adequately treat their pain, it should be very rare that any additional paralysis is needed. So the sedative choices. Benzos are out and out being used in a lot of places. Versed has been around for a long time. It works, takes about 1 to 3 minutes to kick in, lasts about 30 minutes, has some excellent amnesia effects, which is great if you're doing painful procedures or if there's any chance they're going to be aware of the interventions that we're doing in the process of paralytic intubation. It does have some potential for hypotension. It has some potential for respiratory depression, but in this scenario, that's really not an issue because we're going to be taking over the ventilations anyway if we haven't already. The more popular choice currently is etomidate. It is a sedative hypnotic agent and it has a rapid onset, less than 2 minutes. It lasts only about 4 to 10 minutes, which again means you've got to be ready to do your post-intubation sedation because it's likely to be wearing off about the time you've got your tube secured. And it can also cause respiratory depression or it can cause hypotension. And we don't give more than 1 dose of etomidate because of some other issues that can arise. Ketamine is another excellent choice. Ketamine is rising in popularity in EMS protocols for this because its general anesthetic has a very rapid onset. It provides significant analgesia, but with an intact gag reflex. So this is good in terms of the patient still being able to maintain their own airway or protect their airway to some extent right up until the point that we paralyze them. Patients might appear awake because it's a dissociative anesthetic, so they may still be looking around but really not aware of anything. And it lasts about 45 to 60 minutes, so it's likely that it's going to carry through, or the effects of the analgesia are going to carry through a significant period of time after intubation. One caution, you don't want to push it fast. It will cause respiratory depression, especially if it's given too quickly. But it's an excellent medication in this setting. The paralytics. So the paralytic choices, there's several of them out there. These are I'm highlighting a couple of the most commonly used. Succinylcholine, also known as anectine, or most commonly just referred to as Sux in the field, is a depolarizing neuromuscular blocking agent, and the dose listed there is anywhere from 0.3 to 2 milligrams per kilogram, and that is a big range. What you find in most EMS protocols is recommendations that we start very high, very aggressive doses, because in an emergency setting, when we're using these drugs and these interventions, we want to make sure that the dose we're using is adequate to achieve paralysis. So a lot of protocols will just simply have 2 milligrams per kilogram as your paralytic dose. Very good EMS drug because it works quickly and wears off quickly. So that's good for a number of reasons. We're going to get that effect immediately, which we want, and it's only going to last 2 to 10 minutes. That's more than enough time in most cases to accomplish your intubation, to get your tube secured, and to get some sedative on board. If you're not successful, if you can't get an intubation, if you can't get a definitive airway within 10 minutes, it's really good to have that paralytic wearing off, because once we've taken away that gag reflex, taken away any ability of the patient to protect their own airway, if we don't secure a better airway option, we've just made the situation worse instead of better. So a short duration is actually a good thing for our purposes. 2 things to be aware of. The first is malignant hyperthermia. One of the effects of Sux is that in some patients, it may impact their ability to regulate body temperature, and they can get very hyperthermic. So that's something you need to monitor post-intubation, is whether or not they get hyperthermic. If you have a patient, and this is unlikely to happen, but if you find out your patient has a history of malignant hyperthermia, then succinylcholine's off the table and not a drug you're going to use. A more realistic concern for EMS care is hyperkalemia. We know that it can cause, because of the broad effects of muscular reaction that happens with the administration of a depolarizing agent, there's a significant release of potassium in the blood. And in a patient who's already hyperkalemic, that can be problematic. Perfect examples of that are crush injuries or significant burn injuries. In those cases, we need to pick a different paralytic because of those problems. Vecuronium, also known as narcurone or VEC for short, is a non-depolarizing neuromuscular agent, meaning that it doesn't cause fasciculations. It simply paralyzes. It binds at the acetylcholine receptor site and it paralyzes. It's not as quick of an onset, but it's a much longer lasting medication. Depending on the circumstances, the situation, there may be reasons why a longer paralysis period is desirable, but most of the time in the field, the preferred route is succinylcholine, although there are many EMS systems that are now going to either VEC or rocuronium as their first choice, because it's still, the onset is still less than 2 minutes, and there are some arguments that these two have a better safety profile than succinylcholine. So rocuronium is very similar to vecuronium, same general properties. This is a backup in Jackson County. It was added to the protocols a few years ago when we had a shortage of succinylcholine, and this became the first go-to drug for a period of time, but it's now been relegated back to sort of a backup alternative in a lot of places. But again, in some EMS systems, this is your first go-to paralytic drug. So again, the risk of being rapid, of going too fast, is we don't pre-oxygenate enough, we increase the chance of errors, we increase the risk of vomit and aspiration, we decrease our own skill performance, and so I'll talk real briefly about how you can manage some of those factors. So here's why it matters. If you've been in my classes, you've seen this little graph before in the oxygen desaturation curve, and a lot of our critical patients are right there in that 80 to 90, 60 to 85 range on the pulse oximetry, and we're thinking they're really sick and we're right. But what we have to remember is we got to get them to a better place before we take away their ventilations. Before we can intubate these patients, we've got to improve their oxygenation first. That has to be the priority. We need to move them up there. We need to get into a better spot where we have the time to paralyze, intubate, before they drop off that cliff and end up with their oxygen saturations in the toilet. So medical mistakes is another category. If we're going fast, we're more likely to make mistakes. And just to kind of put this in perspective, if you want to think about how hazardous healthcare is, the numbers on the left are how many deaths happen per year. Across the bottom, it's correlated to how often people do these different things. And so bungee jumping is incredibly dangerous, but not very many people participated in it, so there's not a lot of deaths. But what's interesting is that healthcare and mountain climbing are in the same category in terms of your chance of fatality based on number of encounters. Another way to think about that is if you walk into or get driven into our medical care system in this country, your chance of dying is about the same if you choose to climb Mount Everest. That's really alarming, and EMS is no exception. We are a part of this problem. We need to do something about it. Vomiting and aspiration we know is a risk in intubation, and especially when we're going to take someone's gag reflex away. So most of our patients, as I said, are found supine. Then we force air into their stomach with positive pressure ventilation. Then we paralyze them and take away any gag reflex that they might have. All of that just contributes to passive regurgitation. And if we intubate them before they're completely paralyzed, then we stimulate a gag reflex and we add active vomiting to the equation. So that's not helpful. When we talk about skills performance, fight or flight or freeze is probably a better add-on there. We know that our skills performance is kind of on a continuum, and when we're in that rest and digest mode, we are not amped up, ready to get much of anything accomplished. When we're all the way at the other end of the extreme, full-blown sympathetic nervous system response, that's where we have that flight, freeze, fail kind of performance, and that's not optimal either. Where we need to be is in that prime performance. We need to be somewhere in between. We need to break that sympathetic overload so that we're at a level of stimulation, sympathetic stimulation, that's going to get the best performance, where we can be on our toes, notice what's going on, and still make good decisions. So some of the strategies for addressing these things. First one is hyperoxygenation. And so a non-rebreather or CPAP with a nasal cannula underneath it. If it's a conventional cannula, you can run it at 15 liters. There's no problem with that. If it's a capnography cannula, you're limited to 6 liters per minute, but you can run a lot of fluid run a lot of oxygen either way, combine it with one of these. In a patient that needs assistance with a ventilation, then a nasal cannula, again, on high flow, and a BVM with a good seal. And this takes 2 people. You're not going to do it with one person. You have one person with 2-handed grip to keep a tight seal. You use a BVM to administer your ventilations, and you maintain a good mask seal with a PEEP valve on the BVM. That combination is going to maximize oxygenation. That's what's going to buy you some time and get your patient to a point where you actually can do some of these interventions and not have them deteriorate rapidly in front of you. So how do we prevent medication errors? The biggest key to this is have a system and then use the system. So checklists is something that everybody talks about. You got to have checklists. And we have to get out of the mindset in emergency medicine that having a checklist is cheating, or that it's somehow an admission that you're not as smart or not as capable a provider. All of that concept is just absurd, and it flies in the face of all of the good science about human behavior, and especially human behavior under stress. And you aren't more stressed than when you're in a high-risk, low-frequency situation. So checklists like this, having references, doing readbacks with your drug administration, following a checklist, they work. They've been proven in multiple settings, critical settings, in the airlines, in surgery, in a variety of places, that they reduce errors, which means they improve patient outcomes. So find the one that works for you. Develop one that matches your protocols. There's lots of models of this out there, but we have to have checklists. We have to use checklists. We have to break the mentality that we're supposed to just do all of this from memory, because we create a lot of additional unnecessary errors by doing that. The next thing we can do is minimize aspiration risk. So this is the simplest thing we do probably, is just remembering, get this patient in this position. Back up, head elevated. You want their back slightly raised, the head tipped back slightly, their face should be parallel with the ceiling or the floor, their ear should be aligned with the sternal notch. In that position, gravity's going to help keep stomach contents where they belong. The alignment is going to be better for both keeping an open airway when you're ventilating with a BVM, and also for passive ventilation while you're, if the patient's breathing on their own, and they're also perfectly aligned for when you get ready to intubate them. Positioning, positioning, positioning. We can also think about doing things like external laryngeal manipulation. This is not really a position issue, but it's the Selleck maneuver essentially. But when we're doing this procedure, when we're moving those structures, it can help us to visualize, and a little bit of gentle backward pressure will minimize some of that passive regurgitation. It's not going to stop active vomiting, but it may minimize some of the passive regurgitation that can occur in these circumstances. So the next thing is, how do you get to that prime performance? And if you've been in my classes, you've probably heard this before, but it's really important and it's really simple. We need to breathe. We need to remember to breathe. And there's a number of ways you can do this. You can use a variety of tactical breathing techniques. You can use what's called box breathing, which is effective. Or you can just simply slow down long enough to take 3 deep breaths and look around. That's what's going to cause you to go from that fight or freeze mode to more of a fight or flow. Get it back to where you can take in the whole picture, figure out what you need to deal with, gather your thoughts, get organized, and then perform the way you know how to do and the way you can do if you give your brain an opportunity to do so. If we don't create that pause, if we don't slow down our own sympathetic response, we're not likely to be performing at our best. So Dr. Richard Levitan talks about the resuscitation sequence intubation, which is keeping your patient alive during intubation. Same concept, different way of looking at it. The idea is, let's make sure we're doing everything we can to keep our patient protected and oxygenated, so that at the end of the path, we have a secure airway that was successfully accomplished, and we have a patient who's oxygenated well enough that we don't have any brain anoxia as a result of our interventions. End game is focused on ventilation. It's not about the tube, it's about ventilation. And the ET tube is the gold standard for definitive control of an airway. But that can't be your number one focus or your number one priority. And it certainly can't be getting that tube in fast, can't be your priority. So other things to think about: ketamine. Ketamine is a phenomenal drug. It's not the wonder drug. It's not a panacea. It doesn't work perfectly for everything, but we're finding that it's very effective in a variety of these emergency settings, both for analgesia properties, sedation properties. The time frame of it works really well. So something to think about. Pre-oxygenate your patients. We've already talked about this. Lots of oxygen and then lots more. We want to make sure that we got a lot of oxygen going on, and do it for 3 minutes. Yeah, 3 minutes. That in an apneic patient, or in a poorly oxygenated patient rather, seems like forever. But realistically, it's probably going to take that 3 minutes for us to get them where they need to be. We want them up above 93% if at all possible. And if they're breathing, then we can use those first couple methods. If they're not, we're going to bag them to make sure that we can get them where we need them to be. We're going to buy some time so that we have the time to accomplish what we need to without causing them to get a lot worse. So keep in mind that paralysis takes a little time. It isn't immediate. So we got to administer our paralytic, and then we provide passive oxygenation while we're waiting for the paralysis to kick in. That's when we stop bagging, we stop squeezing air in. And think about it. Once you've pushed the paralytic, you're squeezing air into their stomach with no sphincter control to keep it from coming back out. So we don't want to do that. And that pre-oxygenation actually provides oxygenation. It does contribute to alveolar oxygen levels. If we're running high flow oxygen in the ways I described, you are still contributing to oxygen levels and saturation at an alveolar level, even while they're not breathing. And finish strong. Do your intubation, confirm your intubation, sedate your patient, use pain management. Fentanyl is a very good drug for the pain management component at the end, unless you're already using ketamine, and some might argue you can use both. Very good option. Fentanyl seems to be better than the synthetic narcotics like fentanyl seem to be better than morphine in terms of how they work in this setting. Take-home messages from this that I hope you remember: slow down. Take a breath, or maybe 3. Oxygenate your patient, and then oxygenate them some more. Plan, prepare, position, pause. Make sure you've got everything in order and you're ready to do this well. Remember, ketamine is our friend. Paralyze your patient, intubate your patient, sedate your patient, and don't forget that you need to do something for their pain, because intubation is painful. It's not a pleasant procedure, and they may wake up and become aware of it. And if they're paralyzed, you will not have very many clues that they're waking up and becoming aware of the pain. So use the tools that work for you. Use the tools that work for your patient, and in the result of all that is you're going to do some really successful intubating. Slowing down makes us more successful. More importantly, slowing down makes us do a better job for our patients, increases the chances they're going to survive, and increases the chance they're going to survive without a hypoxic brain injury that unfortunately has often been the result when we try to do crash intubations or rapid sequence intubation in the past. Thank you.